I'm one of the cognitive impairment project officers at Fiona Stanley in Fremantle, and I job share with a lady called Jane. So from 2018, her and I sort of done the role full time when the other person's been doing something else. And then last year, Jane was really fortunate to have the opportunity to job share with Sue Winnell. And then back this year, I'm back, so we're job sharing the role across both Fiona Stanley and Fremantle. We're both occupational therapists by background, and my area in particular is Jerry's and neuro, the areas that I'm most interested in and passionate for. And Jane's more of an acute therapist, but she's doing her PhD at the moment, so has a really good background and knowledge and an interest in research. So between the two of us, we feel like we've kind of made fairly good grounds with cognitive impairment and delirium across both sites, but always looking to do more. So next slide, please, Angela. I obviously haven't got technology down pat yet, so I still need help. So what we're going to do is just look at the basics of delirium, what it is, what's out there, and then what you can do at your site. So the basics is delirium, a neuropsychiatric syndrome characterised by disturbances in consciousness, awareness, cognition, attention, and it's an acute change from someone's normal presentation. Symptoms fluctuate day to day, hour to hour, episode to episode, and there are three main types: hyperactive, hypoactive, and mixed. So as you can imagine, hypoactive, which is more often missed because someone's quiet or asleep, very lethargic, that's highly associated or more associated with mortality than the other two. Important thing to remember is, especially if we're thinking about what we can do in hospital, is that delirium is often documented as acute confusional state, acute confusion, happily confused, which is a horrible term, but that's something that we can think about as when we're promoting this, is that even if you're not sure it's a delirium, calling it a suspected delirium, but using that tone so it can get picked up and people become more familiar with that language. Next slide, please. Thank you. So looking at risk factors, again, this is something to think about if we're looking at what we can do to prevent and manage. It's knowing the risk factors for delirium. So over 65, a pre-existing cognitive impairment, so confirmed diagnosis or suspected, severe medical illness or hip fracture, history of delirium and or depression, and then hearing or visual impairment. And then on the right, we have precipitating factors. So again, looking at these, you're probably familiar with the acronym Delirium, that's well used, and it's used here at Fiona Stanley Fremantle. But they're the causes of delirium once someone's in hospital. So if we're thinking about hospital-acquired delirium. So if we're already looking at these list of factors, there are things that not one discipline can manage. So myself as an OT or as allied health, when we go and review someone, we can ask someone's level of pain. Me as an OT, I can look at their ability to take themselves to the toilet. Can they do it? Is their mobility impacting that? Are they able to initiate going to the toilet? Same thing with getting a drink and eating. Can they do it on their own? Do they need help? Can we hand that over to nurses? Et cetera, et cetera. Next slide, please. Thank you. So this is quite an old slide, and hopefully it's clear, but I think it's quite useful. So as we've just discussed, older adults are more susceptible to delirium, but younger adults can get it if the insult is big enough. So we have a graph which shows this. On the left is vulnerability, and the right is the size of the insult. So thinking about someone who is older, has a significant cognitive impairment, might have had a fall and a hip fracture or is really unwell, it doesn't take much to knock them into a delirium. So it could be a change of medication, constipation, dehydration, change of environment. Conversely, if someone is relatively fit and young in comparison, it takes a lot more. So it's why we often see younger adults in ICU, cardiothoracics, haematology. The rates of delirium will be higher among younger, or people who are younger will be more susceptible to getting it. Or you'll see younger populations getting it. Next slide, please. So why is it important, and why do we want to do something about it? Well, it's well written in the literature, including in the national standards, that delirium is an important issue, but it's not very well dealt with, I suppose. The recognition and knowledge of it needs to be promoted a bit more so that we can improve in how we prevent and manage. So these stats are from the Delirium Clinical Care Standards from last year, the new ones. So estimated that about 1 in 5 Australians over 65 have delirium on admission to hospital, and a further 1 in 10 develop delirium during admission. So think about those who are over 65, and that number will increase. And as we've discussed, the rates of delirium will increase with high-risk areas such as heart surgery, ICU. And this little picture, it doesn't really fit with this scene, but I liked it, so I popped it in there. I would have lost it. Next slide, please. So this is a money slide, and before I started this role, so I was a clinician. I'd been an OT for 4 years. Patient care and the welfare of the patients had always been my first priority. And I quickly had to learn that although that's everyone's priority, it's why we work in healthcare, money and finances really matters. So if you want to sell a proposal to someone about something we need to do something about, if you show them how much it costs, and these figures are staggering. So this is I suppose it's quite old data now, but it's a 2019 report. So looking at the financial year of 2016, 2017. So there are estimated more than 900 deaths in Australia associated with delirium, but the overall costs you can see is $8.8 billion. And it's broken down into financial costs and then the costs associated with quality of life and healthy life lost. So this is the community and hospital. So if you think about hospital in particular, so it's patients have longer lengths of stays, high inpatient mortality and complications, lost wows and financial penalties. So although the financial penalty for delirium hack has been removed, it's associated with falls, pressure injuries, infections, etc. So the overall cost is higher, higher staffing costs. And then about 10% of dementia, so delirium causes dementia in about 10% of cases. So you can see that the cost of that's $4.3 billion, which is a lot of money. Now the next line there is one that I found staggering. So it's estimated that the average additional cost for an episode of care with a delirium encounter is $71,000. And that's at Fiona Stanley Fremantle now. So that's current data. And I did clarify whether this is something that's comparable, is it normal? And with comparison, it's got certain limitations. So we're a two-site tertiary hospital with kind of cardiothoracics, head and neck, so complex surgeries aren't at other sites. So someone who's having, say, cardiothoracic surgery, their total length of stay, the cost will be a lot higher. So if you get a delirium, the overall cost will be higher versus say a gen med ward or hospitals that don't have high risk specialties or more expensive specialties really, it'll be a bit lower. But that's a lot of money. So that's kind of worth thinking if we're talking about how we can push the need to do something with delirium. And on top of this, I'll also add, particularly now with the pressure that healthcare is under, is the impact of staff. So a survey that looked at ICU nurses dealing with patients with delirium, but I think that's really comparable across other areas. So they found that managing patients with delirium, the nurses were more prone to physical and psychological exhaustion. So that's due to burnout. They were more exhausted, having to focus more on these patients because of their safety and their own safety. The stress of having to work with someone who doesn't understand. So they're non-compliant. I hate that word compliant, but they aren't able to cooperate. They take a lot more time to be able to do things. They're generally physically and functionally a lot worse off, so they need more physical help. The stress of having to worry about whether their behaviours are going to escalate, how to mitigate that. They're more at risk of other things going wrong, other complications. They're not able to engage in rehab. So all of these things had impact on staff. Next slide, please. So most importantly really is the impact it has on patients. So this is a familiar slide that's been around from the Australian Commission for a while, but up to 40% of cases of delirium are preventable, which is an important thing to remember. But those with delirium have longer length of stay, higher inpatient mortality, greater risk of developing dementia, so estimated 3 times increase in relative risk. The risk of them having a fall, suffering malnutrition, incontinence, pressure areas, so other complications is higher. Higher risk of discharging to a place other than home, if that's where you came from, poor functional and cognitive outcomes. And there's something else to consider is the psychological impact of delirium, both on the patient and their families, particularly given that I don't think the community awareness of delirium is really there. My dad, who's in his 70s but is active and relatively well, had delirium a couple of years ago in ICU, and he wasn't particularly unwell and was only there for one night, but he had a 15-minute episode of pulling out his lines and becoming very agitated. And he still now remembers that and is quite distressed by it. So you can imagine if someone had hallucinations, had a longer period of delirium, what that would mean for them going forward. So next slide, please. So I've just brought this up. You're probably all aware of the Delirium Clinical Care Standard. We've just had our accreditation last week, so I'm very familiar with this document. But it's actually really useful. So not only has it got the quality statements, which I'll show in a moment, but it's got a lot of resources and examples of how you can do things and how you can implement the quality statements in your area. So what I would recommend is having a read through this, breaking it down. It's quite a big document, but having a look and seeing what you can apply and what you can look at other areas and apply to your HSP. So next slide, please. Thank you. So I've put these up there. These are the quality statements. So let you have a quick read. So again, these look at kind of all areas of a patient journey. So from prevention, management, and then discharge information. And it's really useful if you're looking at what you want to do in your area and need evidence for why. Particularly, I'm not sure how other people are going with their accreditation, but this is something that you get managed against or marked against. But it's a useful bit of information and has ideas of how to apply. So next slide, please.
And Katherine, I'll just mention we've asked everyone what they're doing in their sites related to that, and 30% of respondents are doing education to nursing, allied health and or medical. I've asked them to specify in the chat, if you would, everybody, that'd be great. 24% doing delirium screening for all planned admissions, and 23% are focused on prevention strategies. There's others as well, but they were the big ones I thought I would share. And that's out of about a third of your group here.
Okay,
thank you. Carry on.
The next slide, please. Cool, thank you. All right, so while you're answering that, so we'll look at the evidence base. So I might start this with saying that the evidence I've kind of got here really focuses on prevention, because we can imagine prevention is better than management. And really I've looked at the kind of non-surgical, non-medical side of things. But the overwhelming evidence, and there's a couple of recent meta-analysis and systematic reviews that I've included in the reference list that you can have a look at, is that non-pharmacological is better than pharmacological interventions every time. So the main reason for a pharmacological intervention is to treat the cause of delirium, so for example, if you have an infection, or to try and manage a disturbed behaviour, but that's after first-line non-pharmacological interventions have been tried, are already in place and still in place, but you need something additional. And then if you're a patient in ICU, that's probably an area that I know there's research in, but we've not done a massive amount of work comparatively with ICU in regards to their pharmacological interventions, knowing that everything else is happening medically for patients in that setting. Individualised, multi-component, over single component or no interventions is always best, and that's well known and well researched. So there's a significant reduction in the incidence of delirium noted when individualised multi-component interventions are used. And most of the research supports the downward trend in secondary outcomes, so length of stay, duration of delirium, institutionalisation and inpatient mortality. And it's important to kind of mention that although it doesn't statistically impact, say, the length of someone's delirium, think of the impact it has. So if you're applying person-centred strategies to, say, someone's environment or how they interact with them, you're more likely to have an impact on their escalation of behaviours, so prevent them from escalating into a disturbed behaviour, or the agitation rate, or the level of agitation associated with that. People are able to communicate better with you. You're able to get them to take their medication or have a shower, do the things that you need to do and are beneficial for them. It maintains their function to a better degree. And also really useful for family members that sometimes feel that they can't do anything. These are things that they can do when they come and visit. Prevention is better than treatment, which obviously makes sense. And then multidisciplinary over single profession. And that's something that's not often kind of written down as a distinct line in research, but all the research leads to kind of multi-component, collaborative interventions. It talks about using the patient, their carers, their family, health, nursing, medical. So it's multidisciplinary in its nature. In regards to to medical or surgical interventions, there is work in the area of peri-op and pharmacological management. That's done also in looking at the depths of anaesthesia that people are given in surgeries in the area of delirium prevention. And there's also, I listened to a seminar a few months ago now where in Australia they're looking at pathophysiology of the brain and whether that can predict someone developing delirium, and if they do, what kind of delirium. So hypo versus hyper, which is really interesting, and you think about what that means for prevention, how you approach that patient. Equally, knowing that people often have poorer functional and cognitive abilities, so they don't return to baseline after delirium, looking at what can be done in the area of cognitive rehab. So when someone's discharged from home, having an intense period of rehab and what that does to someone's abilities.
Excuse me, interrupting, Katherine.
Yes.
Could I just ask everybody to please mute your microphones? I'm unable to control that from in here at the moment. Please mute it for the distractions. Thank you.
Where in the world?
Thank you, Katherine.
No worries. All right, the next slide, please. So this is a very busy slide, and the reason I've put it in is so that it's a resource for you there for later on. But when I talk about multi-component non-pharm interventions, this is a really good list, and there are lots of lists, and I'll include one of my own at the end, but this is pulled straight from the Delirium Clinical Care Standards. So if you think about what a lot of these things are, they're usual care, or what we call usual care. So nurses, when they go in, they'll check a number of these things, same as allied health, same as nursing, same as medical. They're also what you would do for someone when interacting with them with a cognitive impairment, as falls prevention measures, pressure injury prevention measures. They're nothing that's new and novel. So definitely one of the things that we do in our delirium and cognitive impairment education is we're not introducing something new to what you need to do in your daily patient care. We're not saying you have to do this, this, and this new. It's what you're already doing, but knowing why you're doing it and the importance of doing what you're doing. Now, Angela, has the effectiveness poll gone up before I prompt that? What I'd just like to do is, I know that people, thank you, are writing down what they're doing, but I want to know the effectiveness or how you feel that those interventions are going.
Ooh la la.
Or I can keep going.
Sorry.
You can pop that in.
Yeah, sorry for the delay. It'll just come up in a moment.
No worries. Gives people a chance to read these. So on the next couple of slides, which Angela will get to in a moment, I've included examples of what is done internationally and over East. So there's a lot of research into delirium. There's a lot of work done into delirium, and there's lots of things that we can take from it. So I've just included a couple here, and what I've done is I've hyperlinked all of the websites to the images. So when this gets distributed, you'll be able to access them. But I'll just highlight a few now that I found really useful. So Health Improvement Scotland and the Scottish Delirium Association have a lot of good work. So top right is a booklet they've done for carers and patients who've had delirium. And that's kind of not only useful for what it is, but it's also got information of, now that you've had delirium, the risk of you developing again is higher. So what can you do to prevent it? So it's education. And then the Think Delirium bottom left is sort of a whole of hospital approach, looking at all of areas, encouraging them to think about delirium from before someone comes into hospital to after they've left. So it's all stages in one booklet. At the top is something I've just come across, and I'm really keen to contact them to find out what they've done. But it's a delirium collaboration run by Safer Care Victoria. So it was a multi-hospital program, but the goals of improving care for over 65s who are in hospital by reducing the severity and duration of delirium through early diagnosis, prevention and treatment, and then reducing length of stay and falls of this population. And they did that by having 3 in-person learning sessions where they taught the strategies and facilitated collaboration, had monthly online meetings to talk about data, any successes, any problems, and then ad hoc collaboration via an email. So it seems relatively easy. And they had really good results. So it was Feb 2019 to March 2020. They snuck it in before COVID. But it was, that's the year before COVID. So the results were really good. So particularly with the median percentage of patients screened for delirium within 24 hours, almost doubled. So from 44 to 81%. And then the percentage of patients with an individualised care plan increased from 15 to 87%, which is really impressive. So that's something I will definitely look into more, and anything I find I'll send to tracks for the clinician community of practice. So that's work that's already been done, and hopefully they'll have information of how they've done it. And then on the next slide, please. CHOPS, so the care of confused hospitalised older persons, I think is from New South Wales. I've got that on both. So they're a really useful agency, and on their website they've got key principles and how to implement those principles in a healthcare setting, and then a sort of a project management guide for how to implement change. Something I found above, so that the TRADE project is just a study protocol I found that it looks at the impact of transfer and or discharge on the onset of delirium in older adults, and the feasibility and acceptance of a developed complex intervention targeting caregivers' participation during and after discharge or transfer on cognition and the onset of development of delirium in older adults. So for us here at Fiona Stanley Fremantle in particular, the pressures for beds, capacity and access, wanting to move patients, although it's not ideal to move older adults and patients at risk of delirium, it's often something they have to do. So I'm really interested in what they find. HELP, so bottom right, you're probably familiar with that. It's a program started up in the US with the goals of, among high-risk patients, maintaining physical and cognitive function, maximising independence, assisting transition from hospital to home, and then preventing unplanned admission. And their program is essentially multi-component. non-farm intervention. So early mobilisation and regular mobilisation, reorientation training, pain control, regulation of bladder and bowel, nutrition, hydration, etc. And it's a program that's done not only by clinical staff, but they've got a volunteer component as well. I think there were two that I wanted to raise, but there's lots of stuff out there, a lot of whole of hospital approaches, and covering multidisciplinary and everything from prevention to end of life, discharge. So if we go to the next slide, please.
Yep, and also if you'd like the results of the
yes, please.
The polls. So approximately the same number of people who put in some of the actions that they're doing, and the responses are about 50%, around about 50%. It's neither effective nor ineffective, but pleasing to see 36% feel that it's very effective. It's a rough poll, of course, and any other, there may be some comments in the chat. So if that helps you to talk to Katherine.
Okay. Thank you. That does. And this is one of the things. So when I started in this role, I'd been clinical, had no experience in, say, anything other than being on the floor. Definitely nothing to do with project management. When I kind of first stepped in, and at the time, the HAC delirium, or HACs in general, hospital-acquired complications, was a big focus. And I was tasked with finding a single intervention that would prevent delirium and reduce our HACs, which was a challenge in itself. And the more research I did, the more I found there's a lot that you can do, but it was so overwhelming. How do you implement a whole of hospital approach? How do you create change in a big HSP? And I found it incredibly overwhelming. So what to do and how to do it. And in this presentation, I thought it'd be, yes, it's useful to provide all the evidence, but I suspect we know a lot of that, but it's how do you do it? And I'm by no means an expert in that. But I thought if I've got some ideas, and similarly you guys do, we can all share them. That's how we can create some change. But I've just put this slide in because, creating a whole of hospital is a big task, and I suppose any change that you do is like a mini project. So there's got to be steps to you implementing it. So with implementing any change, you're looking at the project plan, aim, objectives, getting sponsorship, who's your team, who are your stakeholders, do you need to do an audit, do you know your baseline, you need to collect data, align it with something so that it has legs and people pick up on it, designing the intervention, planning it, implementing it, and evaluating the intervention. So there's a lot, and I suppose with this, it's by no means to discourage, but I think sometimes, particularly with delirium, which one of my goals is to make delirium and cognitive impairment increase the profile, but have it the same profile as falls, for example. So I think with us working in hospital, patients at falls risk, generally all clinical and non-clinical staff will know what that means. This person's a falls risk. I know what that means. I know what to do. Whether that's always done, but it's familiar. Or delirium and cognitive impairment doesn't have the same thing. So we need to promote that. So sometimes that can be daunting in doing something big when people aren't familiar. So when I first started trying to do something like this, it was very big. So I was kind of, okay, well, if that's sort of what I'd like to do as an overall, what can we do in smaller steps? So next slide, please. So this is my kind of overwhelmed slide. So this is kind of my general feeling of doing something on a large scale. But I thought here, if it's a good time to put in the chat or a poll in the chat about any barriers. So when you're doing something, and whether you try to do something like this, what are the difficulties? Because I'm guessing, I think most of us are allied health and nursing. So whether that in itself was a bit of a barrier. But all right, next slide, please. So now that we know the evidence is out there, we know that there's stuff already designed and there's programs around. So what can I do? What can we do here and now? as I said, I'm not an expert in this, but I thought I'd share what we've tried to do at Fiona Stanley in Fremantle and some of the successes that we've had, and bits of advice. So what I would suggest is target one aspect. So first of all, know delirium, know the clinical care standards, but pick something. And whether that's you identify that by talking to stakeholders, talking to others, looking at if you've already got audit data, looking what you've already got. But could you pick one aspect of prevention? So whether it's looking at the precipitating factors in preventing those, or really solidifying the multi-component intervention. So make sure people know what they're doing. So with it, education, can you focus on that? Could it be an aspect of management? So is it early recognition, documentation? I'll come to. Is it looking at one area of delirium education? So in what you're doing, I think sometimes, and I've definitely kind of done this lots of times, is you try and focus on a lot of information in one session because you've got a captive audience. Or whether it's, okay, well, let's focus on the prevention and or the documentation of delirium. Could you focus on one discipline or one step within the patient journey? So whether you focus on allied health, so when they go and review a patient, after they're finished with a patient, can they make sure the food and water is visible, they've been to the toilet, or you let them know to go to the toilet, they've got an orientation chart, it's up to date, and can they hand out the leaflets to do with delirium? Or can you look at volunteers and what they can do? Promote something already well known, already in existence, and link to something with a profile. So the example for us is, as I mentioned before, is cognitive impairment and falls. And falls has a good profile. People know about it. People are aware of it. So what we did was, aligning with the need for a comprehensive care plan, is we amalgamated our cognitive impairment screening tool with the FRAMP to create the FRAMP CI. So as I mentioned, to do with comp care and creating one document, but also knowing that the risk factors, prevention and management for falls is very similar to delirium. Why not put them in together? So we've got one form where one risk form where people could document the strategies, individualised strategies, and there's a list of generic strategies, and that's where our 4 ATs, so our delirium risk screen is, as well as the AMT4. But with the education we gave as the FRAMP CI, because it was a whole of hospital document, education went to all levels and all disciplines. I'd say about 60 to 70% of the education was on delirium cognitive impairment, because that was a newer thing. So we associate it with something that was already well known. So we weren't teaching people two things, it was just the delirium aspect. Ask and chat to people. So we've got the delirium, the cognitive community of practice. There are people in WA who are doing this work. We've seen on here what people are doing. During COVID, so the start of this year, when COVID ramped up here, I sent an email out to I found out some contacts of people in the UK and over East for what they'd done to prevent, it was falls and delirium among COVID patients in COVID wards. And I got a really good response. I got probably about 6 responses from the UK and similar from over East. So I thought, given they're really busy, that was really useful, and I got some really good information, given that they'd already been through that. So it's the same thing here. Find an ally. So I found, particularly in the medical side of things, it's really hard to get into medical with any consistency at Fiona Stanley Fremantle. So there's a couple of consultants who are really interested in delirium, so we've made connections with them, so be able to get some work through ED. And then audits. So does something that you audit, does it highlight an area of poor compliance? Is it a knowledge breakdown? Use that and use existing audits to find out information. And one thing we've tried to do is if you can, is things like pharmacy interns, students for honours projects, we've used them to do research. I think now we've used volunteers as well. So if you've got a volunteer program, they could do quick polls, things like that. So next slide, please.
Okay.
The other thing that I would recommend.
And Katherine, did you see the barriers that people have noticed? It really resonates with your last slide there, I think, with time and medical being probably the two biggest things. Yeah. Here you go. Thank you.
Yeah, thank you. So I've kind of commented on a few things there, but I'm glad they're consistent. Or probably should work on how we can fix them. But one of my other bits of advice is know your situation. So know what's happening at your site. So, for example, this is come off the Fiona Stanley Fremantle HAC dashboard, so for delirium. So these are our higher risk specialties. So orthopedics having the most number of cases of delirium this financial year, down to heme. So what do we know about them? So we know that they've got the number of cases, but what are the median ages? What's the how many wows have we lost? So not that it's the financial, because we don't lose any finances from it per se, but think about what that means for, as we mentioned before, so impact on staff, length of stay, increased care costs, complications, etc. And then the percentage that are preventable. So that's something that's really important. So particularly if you're going to target one area, which is one thing I would suggest. So what we've done is we've done some audits of HAC delirium. So the consultant was sent out the UMRNs and they had to fill in a short questionnaire. And one of the questions was it preventable? And our responses were reflective of what national data says. So about 40% are preventable. So for example, for haematology, the average age of inpatient delirium was less than 65 and most of them weren't deemed preventable. So that's probably an area that we wouldn't focus on as much. We'd focus on areas with a high rate of preventability. Like someone mentioned, it's time. So we're very fortunate that we've got a full-time position allocated to this. But doing something, I suppose that is why if you haven't got much time, you'd look at where the area of need is, and you might go with low-hanging fruit, or you pick an area that you're most likely to gain something from. So an area where there's lots of delirium and lots of them are preventable. So for example, with orthopedics, they've got high risk population with falls and also GERES patients, but they're already invested in the sense that it's one of their top HACs. Whilst for something like, for example, gen surgery or cardiothoracics, they've got a lot of them, but they have a lot of HACs because of the nature of their work. What are the competing priorities? So this is something that we've had challenges with, I suppose, with medical and like what you said before, is there's lots of competing priorities. And I think delirium is something that, particularly during COVID, it's kind of at the bottom of the pile, but now as COVID dies down or gets embedded into business as usual, we can come back up. But what are the competing priorities? Can you compete with them, or is it best to find something else? Can you make it a priority? So by showing the amount of money, by linking with consumers, or so for us it was, so what do we need to do for accreditation? And we're already kind of doing things in that area, but what can we do to promote the area that we want to promote? What's already been done? So has there been something done at your hospital before? Has it been tried and did not work, so it's not worth looking at? Or actually now, 4 years later, can we try that again? And the thing I mentioned before is what profile does delirium have? So not just with exec. So a lot of the things is to get them done, you need to pass it through an exec level. So whether it be kind of head of nursing to get through the nurses, or exec in general to get it going, but with floor staff. So something that I'm really keen on, and particularly as a clinician, is when I came into this role, standards, yes, there was something there. I knew a little bit about them, but how do you apply them? So this for me is really important. So how can you make cognitive impairment delirium important to a nurse or an OT or a physio on the ward? Is it by telling them that the hospital is going to save money by you preventing delirium? Not really. It's about the care of the patient. They're not going to escalate. They're not going to stay here as long, etc., etc. I'll just go quick because I realise I've spoken and it's almost time to finish. So I'll just go to the next slides, please. So these are things that we've done at Fiona Stanley Fremantle, which hopefully will give you some ideas. But with regards to the less interesting stuff like governance, so we've got a cognitive impairment committee. We are in the final stages of making our position permanent, so a full-time permanent position. One of us, so Jane and I, now sits on all relevant SAC1 reviews, which is a great way to get education and learnings out to areas where you wouldn't normally be able to reach. We've involved ourselves in the workplace violence and aggression and work that's going on here, which was something that it was a priority, and we've attached ourselves to that. We sit in the Falls Committee. What have I got there? Bottom right is our cognitive impairment identifier. We implemented that really on, and that continues to get promoted throughout all of our education, all of our resources. We've engaged our volunteer service. So we got our model from CHOPS. Was it CHOPS? But on the previous slide, there is an icon, and we liaise heavily with them to get our model. But all volunteers now receive cognitive impairment training. We've also done resources for them for how to engage and communicate with patients with a cognitive impairment, what to do in regards to delirium prevention. And we've tried to embed education. So nursing orientation and care safely days has an aspect of cognitive impairment. We've managed to embed delirium education in intern teaching this year, but that's been tough. Similarly with RMO education, we've got a small slot, but we've got some information in the orientation pack. So wherever you can embed it, so you don't have to do it directly, it's a time saver. Go to the next slide, please, in 20 seconds. These are just some resources that we've created, and I'm more than happy to share. So Champions, the title of this presentation, has come from the acronym that I developed to promote the prevention and management strategies. So that has been made into a poster, and also access cards for lanyard, or lanyard access cards. So on the front is Champions, on the back is Delirium. So one of the feedback points we got is junior doctors are really busy. They're really busy. And if a consultant isn't big on something like delirium prevention in a surgical ward, they probably won't be. But doctor said they look at their lanyard cards for things as templates. So we've been able to get that and mass produce it for them. On the right-hand side, the discharge summary guide. So when I talked about kind of low-hanging fruit, we're looking at improving the identification of delirium and documentation of it on admission. So rather than a junior doctor writing, oh, they're pleasantly confused, is that something they normally are? Or is that new for them? If you're not sure, can you write suspected change in cognition, suspected delirium? That word suspected, you're not diagnosing them, but it's enough to flag with coding and with the next ward that this is something to look at. Similarly, in regards to how it's documented on discharge, we've done templates there, and they're around all the medical officers and in their orientation packs. It's also emailed semi-regularly in their weekly newsletter. So providing information to them rather than having them to go out and get it. And a couple of volunteer things there. So we've done a fair number of resources that provide the information to people as opposed to them having to find it, particularly in times when education is hard to give given COVID and staffing restraints. Doing things like this means they've got the information there. One last slide. I might just have that up while I finish up. My kind of points there. But thank you very much for listening, and thank you for answering the questions and putting stuff in the chat. This is an area that I'm really interested and passionate about. I think there's so much scope to do things, but it's an area that I feel like sometimes we have to fight to get it on the agenda. And once it's there, we can do some work, but that's kind of half the battle. But my other bit of advice is ask questions. You know, contact me or Google, or I'm looking at the Cognition COP. There's lots of people out there who've probably tried something or they've got ideas. I can help you out. There's no need to reinvent the wheel and think of new ideas. But if anyone's got any kind of questions or comments, I'll have a look through the chat, but you can always email me. So on the last slide, I think it's my email address, and I'm more than happy to answer any questions. And similarly, when this gets distributed, you can use the hyperlinks, and I'll attach the references to the slide, so it's a bit easy for you to find and get information. So thank you very much.